Okay, in the new EHA EMN guidelines, we have some differences regarding what we need to know from the bone marrow or the blood and urine tests regarding diagnosis and follow-up of the patients. So, for example, we suggest that during diagnosis and at the time of relapse, the urine electrophoresis and 24-hour urine measurement is needed, but then at the follow-up, the free light chain is enough because it shows high sensitivity. So for the response, for example, a 24-hour urine measurement is not needed anymore. Second, from the bone marrow point of view, for the FISH analysis, we need not only to have translocation 414, 1416, and 1420 like previously, but also we need the addition 1Q, either gain or amplification, the monoallelic or biallelic deletion 1P, and also we need to have the TP53 mutation, along with, of course, beta-2 microglobulin levels in cases of creatinine normal, because these are the new International Myeloma Working Group, International Myeloma Society, new definition of the high-risk myeloma. So we need to check them also. And the third characteristics that we have included in these guidelines is that the diffusion-weighted imaging, magnetic resonance imaging, so diffusion-weighted imaging MRI is a functional MRI that can substitute PET-CT in terms of MRD negativity diagnosis, and that's why you need one before treatment and at the time of MRD negativity. MRD negativity that it was in the previous guidelines, in the previous response criteria, continues to be an important factor because we need to check it in all patients who have achieved complete response, because it's not only a very important prognostic factor, but it may influence treatment decision in the near future. Okay, from the previous guidelines that were published back in 2021, we have several advances only within 4 years. So what these advances include? First of all, they include the two CAR T-cell products, cilta-cel and ide-cel, that have been licensed both in early phases of myeloma, for example, cilta-cel for patients with 1 till 3 prior lines of therapy, ide-cel with 2 to 4 prior lines of therapy, and also in trip-class exposed and refractory patients. We have 4 bispecific antibodies, 3 of them targeting BCMA, teclistamab, elranatamab, and linvoseltamab, that have been licensed either at the 3rd or 4th line of treatment, depending if you are based in Europe or in the US, for patients who are trip-class exposed. Furthermore, we have talquetamab, which is a bispecific antibody targeting GPRC5D that has been also licensed either on 3rd or 4th line of treatment, again depending if you are based in the Europe or in the United States for trip-class exposed patients. We have belantamab mafodotin combinations, that belantamab is coming back with 2 combinations, one with bortezomib and dexamethasone and one with pomalidomide and dexamethasone, both offering very good results in patients with 1 till 3 prior lines of therapy. So as you can imagine, all these new regimens, all these new treatment modalities, along with the previous one, create a very interesting, I would say, but also challenging landscape for the myeloma physicians, because they have to know exactly what to use in the patient that they have in front of them, and it's not so easy to have guideline for every patient. So we have tried to have a guidance according to the previous refractoriness or sensitivity to drugs, and this is going to be seen in the paper that I believe that it will be online during the first 2 weeks of July in Nature Reviews in Clinical Oncology. I think that we try to give, as I previously mentioned, a guidance based on the previous refractoriness of the drugs. I can imagine that this is not easy to say exactly what the doctor has to do in every patient that has in front of him. Every patient is a different entity. There may be comorbidities, there may be frailty, there may be resistance to specific drugs or side effects that the patient had in specific drug classes. So I think that it is important that every doctor see these guidelines as an initial guidance and then to adapt them according to the patients that they have in front of them. But one important issue is the sequencing between especially the BCMA targeted therapies, because as I previously mentioned, we have now 2 CAR-T products and 3 bispecific antibodies targeting BCMA, and also an ADC and antibody drug conjugate, belantamab mafodotin, targeting BCMA. Which is going to be given first? This depends on the patient. For example, at second line, in patient who is both daratumumab and lenalidomide refractory, if he is fit enough, then probably cilta-cel is the best option. But for the majority of the patients that they cannot receive cilta-cel because of fitness or because it's not available, possibly the combination of belantamab with pomalidomide and dexamethasone is one very good option for this specific population. But then we have so many different populations, like the high-risk ones, the ones with extramedullary disease, that of course we have several options, but the new studies, as you mentioned, that they have to be conducted, have also to focus on these populations, like the high-risk patients with extramedullary disease, plasma cell leukemia, who have so many good drugs now that I think we are in a position to use these drugs in order to try to increase the survival or maybe cure some of these patients with high-risk features.